All right, thanks everyone for being here today. I'm Crystal Schiller. I'm a clinical psychologist and researcher at UNC Chapel Hill, where we have a large program of menopause research and a clinical program as well. And we're excited to tell you more about that at the end today. But today we have Dr. Katelin Zahn, who is an OBGYN here at UNC and our wonderful collaborator and colleague who we share many patients with and has really distinguished herself as a menopause specialist. So we are excited for her to talk with us today about hormone replacement therapy and benefits, risks, options that you have that are based on science and research. There's so much information out there, a lot of misinformation and disinformation out there online. People sharing things that worked for them as one person, but what we think is important as medical professionals and researchers is that the recommendations that we make are based on scientific methods to demonstrate what works for who and what works for most people rather than one loud person on the internet. So I'm really delighted to have Dr. Zahn with us today, and I'm going to turn it over to her now, and then we will do Q&A for the second half. So thanks everybody for joining us, and without further ado, Dr. Zahn.
Thank you again for the introduction and for inviting me to be here today. So as Dr. Schiller mentioned, I am a general OBGYN, so I am fortunate to be able to take care of patients across their lifespan and with their obstetric care and their gynecologic care, but my passion has definitely become within the menopause space. And I help co-direct our menopause clinic and am also a Menopause Society Certified Provider and am actively engaged in menopause research and in collaborating with my colleagues in psychiatry and oncology. And I'm just really excited that there's so much interest now in the medical community with regarding to being able to take care of patients during this time, as well as our patients finally feeling like they have the space to do it. All right. So, as many people are probably aware, menopause is a bit of a movement right now. There are influencers online. There are articles about it, documentaries about it, Oprah's talking about it, in our professional community as well. Our society meetings are selling out at the Menopause Society, and our keynote speakers are about talking about menopause. And it's definitely represents this like really important growing conversation about menopause, not just as a kind of a short few years of your life that you need to tough out, but about the kind of the real impact that symptoms can have for patients, and then also about the real life consequences as well. And I think to Dr. Schiller's point, though, there's a lot of confusing information online right now. And so my goal today is to really talk about kind of the evidence around how we can optimize your health during this time. So the objectives for today are to talk about the indications for hormone therapy and examine the evidence for indications, to discuss the candidacy for hormone therapy, to describe benefits and risks, and then to be able to describe and compare different types of hormone therapy. I do think it's important to do a little bit of background on just some terminology and when we're using the words, perimenopausal and postmenopausal and what that means. So across your reproductive lifespan, when you are premenopausal, you're having regular menstrual cycles, very kind of predictable changes in hormonal levels. When patients reach perimenopause, it is broken up into kind of two different categories, even within that. It starts with the beginning of like irregular cycles, meaning from the start of one cycle to the start of next cycle, you'll have more than like a week difference between them. So someone could have been like an every 28-day person, and now they go from 35 to 21 to 32. So those kind of big ranges. And then that's when you can also start to see some hormonal fluctuations and emergence of some symptoms as well. And then there's a little bit of speed bump here because as people transition from early to late menopause and late perimenopause, and that's when patients start to have more than kind of 60 days of without cycles, that's when you can start to see a big increase in symptomatology. And then you'd have your last period. And in the US, the average age of that happening is around 51 and a half. And then perimenopause actually kind of exists as like for the first year after that last cycle. So that is kind of where that definition is there. And then anything afterwards is considered postmenopause. Postmenopause, though, does represent about 30% of a woman's lifespan. And so, again, it's really, really important that we are not ignoring, we're not ignoring this time of life. A couple other definitions. So we have the average age of like when people go through menopause. We know that patients on average can experience symptoms anywhere between, 4 to 7 years before they actually have their last period. There are women who experience early menopause. I mean, they stop having periods between 40 to 45 years old. That happens about 5% of the time. And then there are women who experience premature menopause as well, where they stop having periods less than 40 years old. And that can be due to like unexplained reasons or because they had surgeries that removed their ovaries or they had medications that affected their ovarian function. And the reason that these are important distinctions is, again, today we're going to be talking a lot about menopause hormone therapy and specifically in its role in patients who are undergoing the transition naturally at average ages. The recommendations and risks are very different when patients have premature or early menopause. Hormone therapy is actually indicated for different reasons during that time period too. So menopause hormone therapy, hormone replacement therapy, it kind of gets confused right now. Hormone replacement therapy or HRT is a little bit of an outdated terminology when we're talking about hormone therapy at average ages of menopause, because we know that this is a planned natural event. We expect these hormones to decline, and we're not trying to necessarily get every single patient back up to their like physiologic levels when they were in, their 30s. The goal with hormone therapy during this transition is symptom relief and then potentially goals around kind of certain goals around other reasons for doing it in terms of like bone health, but it's not necessarily always targeting the exact same level that somebody had when they're in their 30s. Now, hormone replacement therapy is an appropriate terminology for patients who had premature menopause. And so that is a subgroup who definitely should be on hormones, even if they aren't having some symptoms. And even though we don't have as much randomized controlled trial data in the early menopause range as well, the recommendation is to have those patients on hormone therapy at slightly higher doses until the average age of menopause for disease prevention, regardless of symptoms. So today I'm going to be using the words menopausal hormone therapy or MHT, but I wanted people to kind of understand some of those differences, and they are used interchangeably, I think, online and a lot of books and how we talk about it sometimes. There's also differences between systemic and local hormone therapy. So systemic hormone therapy means it's achieving adequate blood levels. That's going to be able to offer certain relief to some symptoms. For patients who have more local symptoms related to the vulva, vagina, bladder, that's when we might utilize more local hormone therapy like vaginal estrogen or other type of vaginal products. And then there are important distinctions between estrogen-only therapy or estrogen-progestogen therapy. And that's just because the combination of things can dictate, sometimes the benefits or risks that you may have with them. And so we shouldn't necessarily be kind of lumping all hormone therapy together when we're counseling patients and when we're talking about candidacy and benefits risk for them too. All right. So there are 4 FDA approved indications for hormone therapy. So these should all, in theory, be kind of like green light things that people feel really comfortable prescribing for these reasons. One is hot flashes and night sweats, which are referred to as vasomotor symptoms or VMS. 2 is the prevention of osteoporosis. It is not approved for the treatment of osteoporosis. 3 is for painful sex and vaginal dryness, terms that are sometimes called like vulvovaginal atrophy or dyspareunia. If patients are primarily having those symptoms only and more local symptoms, we would recommend a local hormone therapy rather than systemic in that situation. And then 4th is for patients who have premature menopause. So, like I said, that group of patients who have their ovaries taken out or they have reasons why they're not making any estrogen, that those would be reasons to actually have patients on FDA-approved reasons to have them on hormone therapy. And we would like to think that, okay, they've gone through the FDA approval. That means that we have really good trials that demonstrate efficacy and safety for these drugs, but we know that there are still significant treatment gaps for menopausal symptoms. So hot flashes and night sweats are probably one of the more cardinal symptoms that patients experience throughout the menopause transition. It happens in about 60 to 80% of women across the transition. And yet in 2023, only 4% of women between the ages of 40s to 59 years old, so kind of age eligible women for good candidates for hormone therapy, were being prescribed it. And there are going to be lots of reasons why people are prescribed hormone therapy. Sometimes they may not want it for personal reasons. Sometimes they may have medical reasons. But the reality is that this does not represent the group of women who would be candidates for it. And so we know there still are huge treatment gaps, even for like the green light indications. And then there are also all of the other symptoms that can exist throughout the menopause transition. And we know that it's not just patients having hot flushes and night sweats, whether you are a patient yourself or you are interacting with women throughout this transition or taking care of women during this time period, people are experiencing lots of things. Brain fog and changes in their mood and irritability and, muscle and joint pains and palpitations and a whole host of things that could be related to hormonal fluctuations. We also know menopause doesn't happen in a vacuum. And so there's also the context of, what things could be related to aging, what things could be related to other new medical problems that might start to occur as we get older as well. But I think a lot of people are starting to ask these questions about, can I be using hormone therapy to treat some of these other symptoms that I'm experiencing throughout this transition too? And so there are some other reasons that we use hormone therapy. These are all off-label. That means that like we do not have FDA approval for them, but there are some that definitely have more data than others or that they can be considered. So some other off-label uses that are common are for mild to moderate depression or mood changes. A lot of this work comes from like our UNC colleagues in terms of efficacy of hormone therapy with this transition and the role of hormonal fluctuation specifically in terms of the mood symptoms. Um, for sometimes patients will use it for, metabolic syndrome and diabetes prevention. And while it is not something that, again, has that like FDA label, I think if somebody is having hot flashes or night sweats and has risk factors for these things and or starting to have other kind of characteristics of metabolic syndrome, then I think that's something that like kind of pushes you in that direction. There is some data that patients who take it do have less joint and muscle pain. It is a pretty modest effect, but some patients do notice a benefit. There's less data with anxiety, but certainly some patients notice benefits with that as well. And there's some data to support it, as well as sleep disturbances, even independent of hot flashes at night sweats. And then there are a lot of other things that sometimes used. So, for instance, like if it's biologically plausible that you have like a worsening of a medical condition at the time of all these hormonal fluctuations, migraines, for instance, that sometimes people will use hormone therapy as a trial to see, could it be related to hormonal fluctuations and will my chronic condition improve? I think in these settings, it's really important to have really close follow-up for patients and to be able to kind of establish like what is going to be like our goal, what is going to be like a success so you're not just continuing it indefinitely without the patient's understanding of why they're on it. All right. So these are, common reasons, like I said, that have data in terms of using hormone therapy. I think the next question is, I might have symptoms related to it or things that could be effectively treated with it. If you do, and you want to consider hormone therapy, am I a candidate? Do I have any contraindications that I can't be on it? So there are the contraindications to being on hormone therapy include patients who've had a prior stroke or mini stroke, particularly something that's ischemic in nature. Patients who have estrogen sensitive cancer history, particularly, breast cancer is the most common one, some endometrial cancers, but you want to assess that. Undiagnosed vaginal bleeding certainly needs to be worked up before we're starting hormone therapy. Patients who have had heart attacks, peripheral arterial disease, or really high risk for cardiovascular disease, patients who have advanced liver disease, and patients who have a history of blood clots in their legs, lungs, or genetic risk for blood clots. So if you fall into any of these categories and you're having symptoms, the first thing you'll oftentimes want to be considering is something like behavioral, lifestyle, or non-hormonal medications. There are nuances to all of this. So, I mean, with most of these things, there is not like a hard line where you can't consider it. So, for instance, I have patients who have a history of a blood clot, and, oral hormone therapy is not recommended in this situation, but there can definitely be some shared decision making in using something like a patch or some other transdermal route. I know there's also a lot of conversation online about like hormone therapy used right now in patients who have a history of breast cancer. And again, I think these are really nuanced things, but like the first line, if you have any of these strict contraindications, would be consideration of something non-hormonal. And then if you do not have any of these contraindications or any personal reasons to avoid hormone therapy, the next thing that I'm doing with my patients, and I think you should be doing, in preparation for your visits when you're wanting to talk about symptoms, is to assess your risk related to breast cancer and cardiovascular risk. And so from a breast cancer risk perspective, obviously your family history is going to be really important. We know that family history can increase your risk by about three times. Mammogram density is also important. That is now mandated to be reported on your mammograms. I'm sure you've all seen things like if you have dense breasts, which about 50% of women do, that will be reported on there. And it talks about kind of the decreased ability of mammograms to find cancers, as well as also the increased risk of density on your breast cancer risk. But that's an important thing to kind of factor in. And then also, depending on your family history, you might be eligible for any genetic testing as well that factors into it. There are some individual risk calculators that you can use. There is both the Gale model and the Tyrer-Cuzick model, or the IBIS. These are things that you can do, like patients can do online, and I think are helpful to contextualize, okay, what is my immediate 5 or 10 year risk and what is my lifetime risk? And again, none of these things prevent you from being able to use hormone therapy, but they definitely kind of influence those conversations that we have and help inform them. And then also getting an updated cardiovascular risk assessment. We talked about how patients who have a really elevated risk of cardiovascular disease may fall into a category where hormones like actually might have more risk than benefit. But we also know that this transition is also associated with changes in your cardiovascular profile. And so getting updated information about your weight, your abdominal circumference, blood pressure, fasting glucose, and an A1C, which is kind of an average of your blood sugars over a 3 month time period. Updated lipid panel is all helpful. And you can input some of this information into different types of risk calculators that, again, help inform you. And it helps informs it in both ways. One, can you consider hormone therapy or not? Or two, if you are having symptoms and having some of these other things, and like I mentioned, the metabolic syndrome or, diabetes that's falling into that, maybe you do, consider it in that setting to help reduce your risk.
Kate, are these risk calculators that most people would be able to use, or are these really for physicians?
Nope, you can go online. Anybody can go online and input them. Yep.
So if they just Google these terms,
Mm-hmm.
they'll be able
Yep.
to find it. Okay,
Yep.
great. Thanks.
And then other considerations. So age is a big one that we talk about. So we know based on when we kind of analyze studies and we break it down and we look at patients who are less than 60 years old and less than 10 years from their last period, that is going to be the lowest risk age in terms of initiating hormone therapy. There is no 100% absolute cutoff for initiating it, though. I would say, we also know that as we get older, we may accumulate other medical problems that make it more risky. But like, let's say, for instance, somebody went through menopause at 57 years old and they're now coming to you at 61 years old and they kind of fall into that less than 10-year time period. That's not someone where I'm all of a sudden going to say like, okay, you can't have it because you're now 61 years old. I think we have to take everything into context, and it's a little bit more nuanced. And then another thing that I commonly hear from patients is that they were told that they have a family history of breast cancer, and so they can't be on hormone therapy. And again, family history increases your risk above the average population, but that is not a strict contraindication. And so that's just another thing that I see a reason that being people turned down. That's not true. And then candidacy for menopause hormone therapy does not equal candidacy for other estrogen-containing birth control pills. And this is a common theme that I see for patients coming in and sometimes kind of confusion. So we know that estrogen-containing birth control, that if you're over 35 and you're a smoker or have migraines with aura-type symptoms, that means kind of those visual disturbances before your headache, or you have high blood pressure, that there's an unacceptable level of risk with taking estrogen containing pills. That is not that applies for those estrogen containing pills, and that's because the potency and type of estrogen is incredibly strong and poses a different set of risks. These are all reasons that patients can, these are all reasons where patients can still consider hormone therapy. It does definitely affect the route that we give it or the types of hormones that we consider. And we certainly want to evaluate and make sure they don't have any of those other strict reasons they can't be on it, like a known cardiovascular event. But this is a group of women who I feel like are oftentimes undertreated, despite knowing that like smokers, for instance, are at really high risk of having really severe vasomotor symptoms. Um, so another thing that does differences when we're talking with patients. There was a really nice review from several different societies that met: American Heart Association, American College of Cardiology, ACOG, the Menopause Society, where they reviewed a lot of the data around like kind of rethinking menopause hormone therapy, who we can use it for, and they kind of break it into these kind of three different buckets, so like a green, yellow, and red light. The red light are all the things that we said, okay, you're at really high risk or you've had these known events. We should probably consider, something else first. The low risk category are patients who are recently menopausal, have normal blood pressure, normal weight, are active, have a low cardiovascular risk and low risk of breast cancer. And then the intermediate risk are things that we just need to have more shared conversation around, and that we are also, like I said, it might influence specifically kind of routes and types of hormones that we give in that setting. All right. So, with regards to benefits and risks of hormone therapy, so if anyone has prescribed, received any of these prescriptions, we know that estrogens and progestin all carry a class action black box warning on them. And it's really scary for patients because they'll have these conversations in the office and talk about with their physicians, and then they'll pick it up and they'll read the insert, and it says endometrial cancer and dementia and heart attack and stroke. And this is a big reason that deters patients for taking otherwise very kind of effective therapies that can be overall low risk in their setting. This black box warning is also on all types of estrogens, whether it's a patch or a pill or even vaginal. And there was actually like a recent FDA kind of panel convened to kind of talk about, can we change some of this like black box warning to better reflect the data that we have. To kind of understand where these risks come from and what people are talking about, I do think it's important to talk about a study called the Women's Health Initiative, or the WHI. So I'm just going to kind of briefly review that because I do think it's talked about a lot, and that's actually where a lot of the fear comes from a lot of the medical community and patients too. So we used to prescribe hormone therapy, back in the 70s, 80s, and 90s, very commonly. So up until the late 90s, almost 40% of postmenopausal women were on it. And we were actually starting women on it because a lot of observational studies were showing that there was benefit in terms of cardiovascular risk. So we would have women come in their 70s and actually put them on hormones at that time because we thought it was going to reduce their risk of heart attack. And so that's where the Women's Health Initiative study came in. It was actually trying to ask in a well-designed trial, like, does hormone therapy prevent coronary heart disease and other chronic conditions? And so they randomized women between the ages of 50 to 79 years old. They were postmenopausal women. And they kind of randomized them into two different groups. So if patients had a hysterectomy, they gave them estrogen versus placebo, which is kind of like a dummy pill. And if they had a uterus in place, they gave them a combination pill that had estrogen and progestin to be able to protect those pills. And there were about, 26,000 women between these two different arms. And the trial enrolled patients, and then the initial round of results was released, first with the estrogen and progestin arm. And kind of the world imploded a little bit because, like I said, about 40% of women were on this treatment. And then this trial came out, and prescriptions precipitously declined. And so they had followed women for about a little over 5 years, and they found and reported on the fact that when patients were on these hormones, that they had an increased risk of coronary heart disease, an increased risk of stroke, blood clot, and breast cancer. They did have benefits. So they had decreases in osteoporosis, colon cancer, diabetes. Those were definitely not reported in the media. But those risks is kind of where some of this conversation, comes from in terms of the black box labeling and also kind of fear from the prescription side of things. There are a lot of like valid critiques of the WHI. I think people who say that it didn't offer any valuable information are also a little bit biased there too. But some of the valid critiques of the WHI. So one, the average age was 63 years old. And we know that that's not the average age of patients who are coming in with symptoms. Those are patients typically in their mid to late 40s or early 50s. So we can't necessarily compare apples to apples from that perspective. They said they recruited healthy postmenopausal patients, but a large subset of them, 70% of them were overweight or obese. Many of them were on blood pressure medications. Many of them had high cholesterol and were taking medications for it. This importantly only studied one dose, one route, and one type of hormone. So for patients who were taking estrogen, it was conjugated equine estrogen. For patients who were had to take the progestin, that was a medroxyprogesterone acetate or version of Provera. These are not the most commonly prescribed hormone therapies anymore. There's also the question of had the cardiovascular, particularly when we're talking about the coronary heart disease, like a heart attack, things like that, had the insight already happened. So we know that patients now who have a lot of hot flashes and night sweats, have a higher risk of having cardiovascular disease. When they were enrolling patients, they were enrolling them much later on. So they'd already gone through this transition where they had already had those hot flashes and night sweats. And so had they already had this kind of predisposition when we then started them on hormone therapy. Um, Another big critique is kind of the way that we talk about absolute and relative risk. And this is not necessarily something unique to the WHI. This is kind of with all communication of results from our trials. So, a relative risk is saying something like, okay, there was a 26% increase in breast cancer, which sounds really, really scary. However, absolute risk means, okay, if I'm taking this many people, how many actual people does that correlate to? And we'll talk a little bit about like what those numbers actually looked like, but there's kind of big discrepancies there. And then I think probably one of my biggest concerns is just like how we've applied all these results. One, this trial was never designed to ask patients, like, is this an effective tool for treating hot flashes or night sweats in the menopause transition? This was designed to ask, like, should we be starting all patients on hormone therapy to prevent cardiovascular disease? And I think it did answer some really important things that, like, no, when they're, in their 70s and 80s, we should not intentionally be putting patients on hormone therapy. And we've definitely over exaggerated all of the risks and really not been able to adequately communicate, what are the potential benefits as well. So what they did after they initially reported on this trial is they then broke it down for patients based on age groups. So women who were 50 to 59 years old, 60 to 69 years old, and so on. And what they found is that when you break it down by different age groups, and also by kind of different, there's a much more nuanced story to the benefit risk picture. And so things that I kind of want you to take away from this slide. So the top graph is looking at patients who are on the estrogen only. The bottom graph is looking at patients who are taking both the estrogen and progestin. The red reflects risk. So, here increased risk of blood clot. Blue reflects benefit. Okay. So one is that there definitely were benefits, in terms of hormone therapy, like I said, that were definitely like not communicated in the media and that we've kind of forgotten about as well. Two is that there are important differences between the benefit risk with estrogens and progestin, estrogen alone, or if you need combination therapy. So, for instance, estrogen alone carried some risk but had multiple benefits, versus in this lower graph here, there were more risks with patients taking the combination therapy. And so we can't lump all hormone therapy together. And then the third thing is that the absolute risk of these events happening was still very, very low. So for each of the risks that happened, there was only less than 1 per 1,000 people that it happened to. Okay, so for every 1,000 women that we were giving hormone therapy to, there were fewer than one who actually had a blood clot, a heart attack, or a stroke. Um, I do want to spend just a second talking about estrogens and progestogens and breast cancer, because again, I think that's like one of the biggest fears that people have around taking it. From the Women's Health Initiative trial, what was really interesting, it was only in the estrogen progestin group where there was a higher risk. The absolute numbers of it happening was still low, less than 1 per 1,000 people. But interestingly, the patients who were taking estrogen alone actually had a trend towards a lower risk of breast cancer. This was the WHI was a randomized control trial, meaning that we randomly put people into groups and we randomly give them hormones and kind of monitor out. So those are kind of the gold standard trials. We have lots of other observational trials, meaning we know women are taking hormones and we kind of look at snapshots in time. And from these trials, the picture is a little bit different. So it does depend on the dose, it does depend on the formulation or type of hormone, and it does depend on how long you're taking it. Um, for patients who are taking, estrogen and progestogen, so they have a uterus, that is probably the group that carries some higher risk in terms of breast cancer, but the type of progesterone probably matters. And so there is some data that when patients take micronized progesterone, the ones that kind of structurally similar to what our ovaries make, that is at least the data we have for when they're taking for at least 5 years, that there's no association with breast cancer in these case control trials. And then another important thing that when we're just kind of contextualizing risk with hormone therapy is that, like, when we compare alcohol use, physical inactivity, and hormone therapy is still less risky than consuming 2 glasses of alcohol a night. So again, these risks may exist. They may be very, very small though, and there are other things that we can do to mitigate it too.
Just want to clarify one point really quick. You're saying micronized progesterone is the best progesterone option in combination with estrogen, right? You're not suggesting micronized progesterone as a treatment by itself, correct?
So some people do use micronized progesterone as a treatment in and by itself. I'm talking about it specifically if you're having to take combination therapy. The concern was based on the Women's Health Initiative that patients, only the people who had to take the combination had a higher risk. So how does that progesterone matter? And this might be the safest one then from a breast perspective. Yeah.
Great.
All right. So this is why the Menopause Society says that for women less than 60 years old, less than 10 years from menopause, and don't have any of those strict contraindications, in general, the benefit risk ratio is very favorable for treatment of like bothersome like hot flashes and night sweats and prevention of bone loss. And then there's a question about like how do we choose? Okay, so I have something that I think might be treated with hormone therapy. I understand what those benefits risk and I don't have any reasons why I can't take it. How do I actually choose which one I can take and how do I how do I take it? And so these are kind of the ways that I kind of break down that thought process. One, do you need estrogen, progesterone, and both? How should we give it and what types of hormones? So when you're deciding estrogen or combination, estrogen is oftentimes what patients need to be able to alleviate because those are truly where like most of the hormonal fluctuations are coming in. If you have a uterus, you need something for uterine protection. Okay. And that's where that progestogen comes in. And I say the word progestogen, which many people may not know, but basically that means anything that acts on the progesterone receptor. And there's a couple nuances in terms of like, is it similar to what our body is making, or is it something that's kind of made up in a lab and acts on that progesterone receptor? That can, so like I said, it can be in the form of something called a progestogen. There is also a really interesting medication we'll talk about that is not a progestogen, but offers that uterine protection. But the big thing for you to know is if I have a uterus, I need something to protect my uterus. I'm giving it, if I'm taking estrogen, we have studies, there was a period of time where we're giving patients with a uterus estrogen alone, and they had higher risk of precancer and cancer. If we give you a progesterone with your estrogen, you actually have a lower risk of uterine cancer. If you do not have a uterus anymore, it is okay for you to take estrogen only treatment. There are a couple other situations where I do consider it. So let's say somebody has a history of endometriosis, they had a hysterectomy. That is a setting in which I may consider adding a progestogen in. And that's because, especially if they had really advanced endometriosis, there can still sometimes be little tiny endometrial implants that could be stimulated if we give you estrogen only. And then it is also okay for patients to use something like progesterone, even if they've had a hysterectomy for some other benefits. So a lot of the times patients may notice a benefit of sleep or mood, anxiety with taking micronized progesterone, and it's incomplete relieved with like the estrogen alone. So just because you've had a uterus doesn't mean you can't take it. Or you had a uterus taken out doesn't mean you can't take it. Okay. So with estrogens, it's kind of broken down. There are different routes we can give it. There are different types. This is kind of meant to be like an overview of all the different things. I don't expect anybody to be able to memorize it. I think I want to just convey that there are a lot of different options available. So with routes of estrogen, 'cause I do think this kind of is one of the more important distinctions for patients, is that you can take an estrogen pill. Or you can take an estrogen transdermally. And I think you'll hear a lot about like estrogen patches, but there are also estrogen sprays, there are estrogen gels, and there is even a vaginal ring that is estrogen based that it gives systemic levels, means gives adequate blood levels to be able to treat things like hot flushes and night sweats. The patches are something you typically place and change every like 1 to 2 times a week, depending on the brand. The sprays and gels are things that you apply daily. And the vaginal ring is something that you can insert inside the vagina and it's left in place and it can be left in place and just changed out every 90 days. In terms of differences between the transdermal approaches or the oral approaches, so the oral estrogens can increase HDL, which is your good cholesterol. It can lower your LDL, which is your bad cholesterol. So those are all good things, but it can also increase your triglycerides, um, which is a negative thing. From a cholesterol standpoint, with something that's transdermal, the effect, you may get some beneficial effect in terms of it lowering your LDL and potentially lowering your triglycerides as well, but it may not be as pronounced with oral as with oral estrogen. In terms of oral estrogens, small increased risk of blood clot with no impact if you're taking something transdermally. Same thing with gallstones, small increased risk with oral. Libido is something I think about too. So oral estrogens, they get when you take it, it then goes through your liver first, and so it can activate, clotting factors. That's why you can have that blood clot risk, but it can also increase production of other proteins, in particular one called sex hormone binding globulin. And this can bind up free testosterone, which is why some patients notice a decrease in libido when they take that. And so it's something when I'm assessing patients, other symptoms they may be having at this transition. And then again, because it gets metabolized through your liver first, there's a little bit more variability in terms of the oral estrogen, in terms of like levels that you're seeing in your body. For a lot of women, that's not a problem. But for some women, particularly from a mood perspective, they may be really sensitive to that like variability there, where you may opt for something that has more of like a steady level. And then there are different types of estrogens. So there is estradiol, which is the compound, the estrogen that's made by our like growing follicles. There's conjugated equine estrogen, which is Premarin. That's what was used in the Women's Health Initiative. There are conjugated estrogens, ethinyl estradiol, which is what's in a like traditionally in the combined birth control pills. And then estradiol as well, which is actually a human estrogen. It's made by the fetal liver. And it's actually in a product right now that's in a version for contraception, but they're actually studying a version of it right now for hot flashes and night sweats too. Again, I don't expect anybody to memorize this. There are differences between it. The people right now talk a lot about like bioidentical estradiol, and I think I've seen on these prior lectures that people have kind of also addressed this point that it is really a marketing term. Um, Estradiol, whether you get it, bioidentical estradiol is the same as the estradiol that you can get as an FDA product. And so I think this is the most important thing. If someone is like telling you that you have to buy the estrogen from them or it has to be compounded from them to get the bioidentical effects, that is not true. There are formulations that will be covered by your insurance. And then like I said, if you have a uterus, then you do need uterine protection. The ways that we can get that uterine protection, that's a progestogen, can come in the version of a pill, a patch, in a combination, something that actually goes inside the vagina, and then also intrauterine, like an IUD. This is an off-label use, but like the Mirena and Liletta do have data to support for uterine protection. I will say the difference between that and when we use it for contraception is for contraception, we can use it for 8 years. When we're using the IUD for uterine protection with hormone therapy, we only have data for 5 years. So that's kind of an important distinction when you're managing patients for that. And then the other thing is that a lot of patients will talk about taking progesterone creams. We'll get that prescribed. You can buy it on Amazon. We don't have any data that progesterone cream is effective for uterine protection. So if you are taking systemic estrogen, meaning as a pill or a patch or something that's getting higher blood levels, you need to be taking one of these other studied routes. And then with regards to the types of progestogens, so there is progesterone, that is again structurally similar to what your ovaries make after you ovulate. This is what people market as like the bioidentical progesterone, but there are FDA approved formulations of it. And then there are progestins, which means that it's not found in our body, but it can be synthetically made, and it acts on the progesterone receptor. A couple points with these prescriptions. So the progesterone is suspended in a peanut oil. So if patients have a peanut allergy, that's a reason that they can't take progesterone, micronized progesterone. So if that's a setting, you might consider, doing one of the progestin agents or compounding without it. If you get a prescription from Canada, they have it suspended in sunflower oil. If patients have really heavy periods or want to prevent pregnancy, the progestins are probably going to be a little bit more effective about it. And that's where you may consider something like a progestin pill or an IUD. And then if someone has like significant mood symptoms or sleep symptoms, you may consider, micronized progesterone. And that's because one of the metabolites of it can act centrally to help promote sleep and anxiety. And then I do want to mention for patients who have a lot of side effects with the progesterone. So they know they need to take it to protect their uterus, but they have a lot of bloating or they have a lot of breakthrough bleeding or headaches, or they just really don't feel well on it. We do have a medication option that offers that uterine protection. The medication is called bazodoxifene. And what's really interesting about this is that it either binds to or blocks estrogen receptors differently throughout the body. So it blocks those estrogen receptors in the uterus, which is how we get the uterine protection. What's interesting about this is that it also blocks and breaks down estrogen receptors in the breast. And so a lot of people are kind of wondering, can this actually be like potentially protective approach when patients are taking hormone therapy? The the data around that, so we know that this medication does not have any effect on breast density, which like more traditional hormone therapy can sometimes affect. And then there was some really interesting data looking at patients who have kind of early stage breast cancers, DCIS, and this is again really small short-term follow-ups. They basically those patients had that diagnosis. They gave them this medication. When they had their surgery months later, they did show a decrease in kind of breast proliferation in patients who had that. So I think this is a really exciting space that we're going into. It's not definitive that like you take this and you're going to reduce your risk, but this is something that I factor in with patients who have really elevated breast density and are worried about how hormone therapy might affect that, or if they have that family history, or that's kind of one of their concerns. It is FDA approved for treatment of hot flashes and night sweats, as well as prevention of osteoporosis. It only comes in combination with conjugated equine estrogen. So here in the US, we can't just get this pill separately and then give somebody like an estrogen patch. So it has to be this combination product. Because it is a combination product, it doesn't give us a lot of like wiggle room to figure out, if we need to adjust your dose of estrogen a little bit, is that going to work? Unfortunately, this dose of estrogen is a little bit lower than the kind of standard doses that we use. And so some patients find that it's just not effective enough to treat some of their symptoms. So I definitely consider this medication for patients who have side effects with the progestogens. If they're having, persistent abnormal bleeding on hormone therapy, you might switch to this. Or again, if they're concerned from the breast perspective, because this is not increased density or does not increase breast density, or they have those concerns, that may be another reason.
Just one quick thing I want to add there, if you don't mind. So for some of our patients that we treat in psychiatry, a significant number do have irritability with progesterone, even the micronized progesterone. So if that's something that you're experiencing, it's worth considering Duovy, so that you don't have to take that progesterone. I think that is not widely known, and so your doctor may not have told you about that potential risk. And so I feel obligated to bring it up whenever we discuss this. And then the other thing, what was I going to say? I don't remember now. I lost it. But I think it's important to know all of that. And oh, the other thing I was going to say is that I have co-treated a couple of patients with Dr. Schiff in OBGYN at UNC, and Dr. Schiff has put people on double the dose of Duovi. That's off label, but to increase that estrogen level without having to expose them to progesterone. So that's just another thing to keep in mind. It's not as flexible in the dosing as Dr. Zahn said, but there are still options.
And then I know we talked about what people think of as kind of more traditional menopause hormone therapy, but I do want to just talk about, kind of low dose birth control pills, because I think they sometimes get kind of neglected in the perimenopause transition, but they can be really effective tools for women still. So we know that perimenopause, kind of the graph on the left here, is characterized by these really kind of unpredictable hormonal fluctuations. And it's those fluctuations that we know are actually responsible for a lot of symptoms. When when we are giving, menopausal hormone therapy, we're kind of giving back lower doses. And so we're going to kind of soften the drop that patients have in terms of fluctuations. When we give something like a low dose birth control pill, we are giving high enough levels to kind of like shut off what the brain is signaling to and saying, hey, I got this. I'm going to give you the kind of the same amount of progestin and same amount of estrogen every day. And so that's what kind of this graph on the right represents, is kind of this is what the hormonal level pattern looks like when patients are typically taking a hormonal birth control pill. So I just wanted to say that like it can be an effective tool during this time period. And so I don't want people to think that like the traditional menopause hormone therapy is like the only route. And then particularly for patients who have really like heavy irregular periods, if they need contraception during this time period as well, because not all hormone therapy when we use it perimenopausally is contraception. If they have significant PMS or PMDD, it might be something to consider.
One other question that came in from the audience about this, Dr. Zahn, is that what happens or how does treatment work for women who are already on like long-standing birth control pill or oral contraceptive? Would you recommend that they change that in any way as they approach the menopause years, or would you keep them on whatever they're already taking and for how long?
Yeah. So I kind of depends on what your goals are and what your needs are during this transition. So like I said, one great thing about perimenopause is really is characterized oftentimes by significant changes in your periods and irregular bleeding. And one of the nice things about, low dose birth control pills is that they definitely offer that like predictability and control of that. They also offer some of that stability of hormones. And so patients can oftentimes notice a benefit, like they're not getting hot flashes or night sweats because it's really a lot of the hormonal fluctuations that are contributing. Unless you have, those contraindications that I talked about in terms of, birth control pills. If you're a smoker, if you have high blood pressure, if you have migraines with aura, those would be reasons why I'd say you should not be on the birth control pill and we should consider one of the other routes. Sometimes patients, when they do become perimenopausal, they do notice like, okay, if I'm taking those 3 weeks on, and then I have that last week where I get my period, where you're taking kind of those sugar pills that you might have symptoms emerge. If that's the case, you can switch to kind of more of a continuous route. So again, you're having kind of the same hormonal exposure. And then there are some patients where, you're doing the continuous route or you kind of troubleshooted some of those things and you're still kind of getting breakthrough symptoms. That might be another time period where, depending on whether or not you need contraception or something like that, but I might consider switching to, hormone therapy, menopausal hormone therapy. The estrogen that's in birth control pills is, like I said, ethinyl estradiol most commonly. And, different types of estrogens bind differently to different types of estrogen receptors in our body. So in our brain in particular. And so some patients do notice that they do a little bit better when we switch the estrogen formulation or type. So I do not, if people are doing great on it, I don't necessarily inherently switch you. And then I also want to reassure that like when you're taking the low dose birth control pills, you're also getting that good protection from a bone perspective too.
At what age do they need to switch, or they can
Yeah.
take it forever?
No, so we do not recommend combined birth control pills when patients are postmenopausal, because it's a like high enough dose that you don't need to that you don't need that. You're not trying to suppress ovulation or for anymore. And so people might be like, well, how am I going to know when I'm menopausal at that point? So usually what I do for patients is, around the average age of menopause, 51 to 52, I might have you come off of it. Sometimes I will have patients, you can check hormone levels, not while you're on the pill, but about 4 to 6 weeks afterwards. And sometimes I will have patients get their levels drawn at that time point, just because if they're normal, it tells me like your ovaries are still, still chugging along, that like one, you might get bleeding. And so patients may consider going back on it for another 6 to 12 months. And just so they have some kind of expectations around what to anticipate when they stop it. Um, So hopefully this was like kind of a good overarching overview about some of the like menopause hormone therapy 101. Like I said, it should be the gold standard treatment for hot flushes and night sweats. There's some evidence for other menopausal symptoms. Um, Women less than 60 and less than 10 years from their cycle ending without contraindications, the benefit risk ratio is very favorable. And there are many different routes and types and doses of estrogens and progesterones and non-progestogens that influence benefit risk on your symptoms. And so I think that's another thing is if you're only being told like I'll only offer this one thing to you, I think that's a time point to like maybe potentially consider seeing, a menopause specialist at that point, because you do have a lot of options to be able to kind of support your health and treat your symptoms throughout this transition.